Welcome to the module on renal and urological problems. There are a lot of different problems that really can include anything from an infection, obstruction, metabolic issues, trauma, neurological. There's going to be a lot of different kinds, so we will look at those during this lecture, but make sure to spend some time really differentiating the different types of problems that can occur. So one of the well-known is a UTI, a urinary tract infection. Sites of infection include in the upper and lower urinary tract. Usually the bladder is a very sterile area and environment, and the urethra as well. But sometimes due to acid pH issues, high urea concentration, just different things that can occur, these people can get UTIs. UTI is usually ascending from the urethra and moving upwards. So a lower UTI is the main one we think of. Some people can have upper UTIs, which we'll talk about. Germs from the perineum move up towards the bladder and sometimes even higher. These areas usually are considered sterile, but usually it's some kind of either germ, or it can even be a urological instrumentation from outside the GU tract going into the GU tract. This could maybe be a Foley, cystoscopy, even sexual intercourse, things like that. These can cause different kinds of UTIs. One that we will talk about pretty quickly too is healthcare associated infections. These are big things for reimbursements for hospitals. One of them is called a CAUTI, a catheter associated UTI, basically. Those go against the hospital because we try to not give our patients infections. So if we want to take out catheters too long, maintain sterile techniques, perform different Foley care, perineal care, and there's different things they can do to prevent those kind of CAUTIs. All right, so upper UTI, usually what we think of as pyelonephritis. It's the inflammation of the renal, perineum, and other systems. Usually pelvis, ureters, signs and symptoms are more systemic than the lower UTI, which is more localized. You can have fever, chills, flank pain. This can even progress to what we call urosepsis. It is a UTI that is spread systemically throughout the body. Lower UTI can be, cystitis, inflammation of the bladder, or urethritis, which is inflammation of the urethra. Usually there are no systemic symptoms. Signs and symptoms are like pain with voiding, suprapubic pain, frequency, urgency, cloudy urine, and those kind of symptoms. Diagnostics, big one is a UA, or really a clean catch is what we want to call this. This is a midstream where you want to urinate a little bit into the toilet and then you urinate into a cup. Usually you also, before you urinate, clean front to back really well with a wipe, and then do not let anything touch that sterile cup. You don't want it to touch the perineum. You don't want to give a false reading or contamination. Urine culture usually comes from that UA. Best is a straight cath, but we're also, you got to think pros, you get the best accurate result, but cons, you also put a risk of giving the patient a UTI. So it kind of is a pro versus con. I've seen different hospitals do different policies. A lot of ERs say, oh, you can't pee. All right, we're going to cath you to get a UA. Where some other hospitals say, okay, you're unable to pee, why don't you hang out? We'll give you some fluids for an hour and see if we can get you to pee. So there's different kinds of, approaches that different hospitals have for that clean cat or the urine culture. And then CT scan is usually done if an obstruction is suspected. Drug therapies, antibiotics. After UTI is diagnosed, they need some kind of antimicrobial therapy depending on your clean catch or your urine culture. Sometimes they will do a broad spectrum antibiotic for a while and then come back and be like, okay, now we have the sensitivity for this UTI, we will use this antibiotic. Another analgesic that we can use that really can help with that bladder pain that they have is called Pyridium. It has no anti-infective qualities. It just really is to help with that pain. It does turn urine orange, and if you are treating a child's UTI and you give them Pyridium, it can stain their clothing really easily, and that works well for elderly adults too. So that is a big teaching topic to warn people when you're, seeing them with Pyridium. Lower UTI, urethritis, is the inflammation of the urethra, usually caused by bacteria, viral infections, and your symptoms are usually pelvic pain, dysuria. Usually antibiotics and NSAIDs for pain is the best way to go. So lower UTI, there's the interstitial cystitis. There is a thing called painful bladder syndrome, which is inflammatory disease of the bladder. It is chronic, cause is really unknown. Sometimes the patient has periods of remission and flare-ups, things like that. Pain is usually made worse by bladder filling, putting off going to the bathroom, and pressure against the bladder. Clinical manifestations, usually chronic, very painful. Usually diagnosis is confirmed by exclusion of all other urinary tract issues. And really it's a treat the pain and make dietary changes. Avoid things that are going to irritate the bladder, such as caffeine, vinegar, hot peppers, citrus, anything that's going to irritate that bladder. So make sure to look at what patients have the highest risk factors for UTIs. This could be the elderly, women because they have a shorter urethra. It's important to know those risk factors in your book. And then big teaching topics, ways to prevent UTIs. Empty bladder regularly and completely every 2 hours. Evacuate bowels regularly. Constipation can cause UTIs. Wipe from front to back in the case of females. Drink adequate amounts of liquid every day. And avoid unnecessary catheterization. Make sure to spend some time thinking about if you were asked a question of your patient asks, hey, I have this issue with UTIs. What are you going to educate that patient to? It's a big one. So upper UTI is usually called acute pyelonephritis. It is usually located inside the kidneys. It usually progresses from the lower tract up to the upper tract, but it can be caused by some kind of obstruction in the lower tract as well. So let's say you have a kidney stone or some kind of stenosis. The urine backs up back into the kidneys, which can cause a infection as well. This is a very pretty picture of some kidneys with the cortical surface shows the grayish white areas of inflammation and abscess formation. We don't like abscesses forming on our kidneys. Clinical manifestations, usually mild fatigue, fevers, chills, nausea, vomiting. Flank pain is a big one that people think of. Dysuria, urgency, frequency, and then really those can progress into a systemic issue. That's the fever, chills that can cause that urosepsis. Diagnosis, we want diagnostics, we want a UA. Usually you have positive bacteria, increased white blood cells, leukocytosis, hematuria. Those are very common. And CT and ultrasound can be done to confirm inflammation of that area. Blood cultures are extremely important before you give any kind of antibiotics. That is because you want to find out if it has moved systemically. If it has moved systemically, you want to get those blood cultures before you get antibiotics because that can really change your results. IV fluids, antibiotics, pain meds, all those are very important. Again, we usually start with a broad spectrum antibiotic until we get a sensitivity report back. When that report comes back, usually you change the most effective antibiotic. So sometimes they'll give, for example, vancomycin and Zosyn, and then they say, oh, once that we get sensitivity report back, it's actually Zosyn that is more sensitive, so they don't need vancomycin. Better start strong, get as much antibiotics in there as possible. And then antipyretics to decrease fever, and pain meds such as NSAIDs and Tylenol. So common immunological disorders, you have glomerular nephritis, inflammation of the glomerulus inside the kidneys that can be caused by infections, drug toxicity, systemic diseases, and problem with the immune system. It usually can be acute or chronic. And then you have nephrotic syndrome, which results when the glomerulus is excessively permeable to plasma and proteins, causing polyuria that leads to low plasma albumin and eventually tissue edema. So glomerulonephritis, the clinical manifestations, one important thing to note is it's usually post-streptococcal. So after you have a strep throat infection, it may develop 1 to 2 weeks after that, especially if they do not have any kind of antibiotics. This is important why we teach people that with strep throat, you need to get on antibiotics for this reason. A lot of times undiagnosed, untreated strep can cause these kind of renal issues, and it can also cause cardiac damage, which is huge. Clinical manifestations usually have generalized edema, a paraorbital first, which is around the eyes, oliguria, which is very low urine output, hematuria, proteinuria, high potassium, low GFR, high blood pressure due to fluid overload. This patient appears puffy. They don't appear dry like you would think with somebody that has low urine output. Usually collaborative care, we want daily weights. We want sodium restriction and diuretics to help pull this fluid off. Hypertension medicine if needed. Protein restriction if BUN is high. And calcium gluconate given IV to decrease potassium levels. Just a reminder, potassium is deadly. High potassium levels and low potassium levels can be deadly to a patient. So we really want to treat potassium before it causes cardiac issues. Nephrotic syndrome results when the glomerulus is excessively permeable to plasma proteins. This causes proteinuria that leads to low plasma albumin. Low albumin causes fluid to leak out of the blood vessels and into the tissue, which causes that peripheral edema. Common causes: NSAIDs, heroin, bee stings, leukemias, bacterial strep, HIV, and diabetes are big ones. Clinical manifestations: you have that peripheral edema, massive proteinuria, hypertension, hyperlipidemia, and hypoalbumin. And then you might have possible signs of thrombus or emboli as well. Collaborative care and drug therapy: daily weights and strict isonos, sodium restriction. You want to give albumin and diuretics, and anticoagulant therapy such as heparin for those possible emboli. And then decreased lipidemia as well. Potential complications is that thrombus is decrease in the blood flow to an area due to a clot, and emboli, which is a clot that has completely occluded blood flow. So both of those are things that we are monitoring for and being careful of. A pulmonary emboli can be an emergency. It happens about 40% of nephrotic patients. You're going to watch out for shortness of breath, and chest pain is another big one. All right, obstructive uropathies refers to really kind of any anatomical or functional condition that blocks or impedes the flow of urine. Risk factors can be found in your book. It's an important thing to know. This can include stones, strictures, tumors is another big one, and inflammation. So as you can see in this picture over here on the far left kidney, you can see this kind of foreign body or a calculi. On the far right, you see a stricture. So it's important to kind of know all these different kinds of obstructions that can occur. Big ones: kidney stones, urinary tract calculi. Stone formation really is affected by urinary pH, solute load, and inhibitors in the urine. Other factors: obstruction with urinary stasis, UTIs, and a lot of it can be genetics. There are 5 different types. There is calcium phosphate, calcium oxalate, uric acid, cysteine, and struvite. So in your notes for your reading, you can see a little table. I highly recommend you fill that out. What are the different types? How do they manifest? And what kind of causes those? So usually clinical manifestations, you have sudden severe pain with obstruction. Some people call it the kidney stone dance. They literally cannot stand still, or sit still. They go from walking to sitting to lying down, and then they kind of repeat that process. They cannot lay down and stay still. Mild shock with cool or moist skin. Pain moves from moves to lower quadrant of abdomen as stone nears the UVJ, which is the juncture. Testicular versus labial pain depending on the gender, and both sexes usually experience a large amount of groin pain. You can also have a lot of UTI symptoms, the dysuria, fever, chills, that kind of form from that calculi. Diagnostics, usually non-contrast CT, ultrasound, you can have an intravenous pyrography, and then usually they do a complete urinalysis to assess for hematuria and crystalluria, which is just crystals in the urine. An acute attack, we're going to give some kind of opioids to kind of relieve that pain. A lot of people will clamp down, is what we call when they're having these kidney stones, and that clamping is actually makes it worse. So we treat their pain, we treat for infection, we can give them medications such as Flomax or Hysterine. Both of those are given. They're a alpha adrenergic blocker that relaxes the smooth muscle in the ureter, so it keeps them from really clamping that down. It lets them relax. Flomax is given a lot to men who have BPH or prostate issues to help with that flow of urine, so it's kind of the same idea. And then assessment of the cause, diet, inflammation, or infection, genetics, kind of see what's going on there. So this is what you see in a lot of hospitals. It's a urine strainer. So we can send people home with this as well. But any kind of urine that they have, you strain it through that strainer and you can actually get pieces of stone. You can document that pieces of stone. We can say, great, they've passed that stone. And we can even do some testing on it to see what kind of stone it is. So what if it doesn't pass even with those conservative measures? Then we will have to kind of go for some other procedures. The big one is laser lithotripsy. It's used to break up those larger stones that may be stuck in a certain area. Usually they get up close to the stone, a small fiber is inserted into the endoscope in the tip, which emits laser energy that comes in contact with the stone and breaks it up. Sometimes, though, that still doesn't work. Sometimes patients need a stent placed to keep the ureters open so that the stone can pass, and then that stent is removed later on. So teaching is very important for those with active formation to keep them healthy and from preventing them from coming back into the hospital. Big one, adequate hydration, trying to flush that stone out. If they're in the hospital, that means IV fluid. If they're at home, it means large amounts of fluid. Dietary sodium restrictions and other dietary changes, such as a purine stone, which is uric acid, is a waste product of purine foods. So patients should avoid foods like sardines, liver, chicken, salmon, pork, beef, alcohol. With calcium stones, those patients really should avoid milk, cheese, ice cream, fish with fine bones like sardines and herring. For the oxalate stones, that could be avoiding dark leafy greens, asparagus, tomatoes, and chocolate, which is a sad one. And then also drug therapy. There are some different ones that can alter urine pH and prevent excessive urinary excretions of a substance, depending on which kind of stone there is. All right, urinary retention. This is can be caused by a bunch of different kinds of things. It could be caused by things such as bladder outlet obstruction, an enlarged prostate such as BPH, deficient destructor contraction, which is basically the bladder muscle is no longer able to contract to completely empty the bladder. This could be a neurological disease, a long-standing diabetes where they have poor control, chronic distension, chronic alcoholism, and there's different kinds of medications such with anticholinergic properties, such as tricyclic antidepressants, and even overactive bladder medications like ditropan, which causes urinary retention. A lot of the diagnostics starts with information from the patient. avoiding diary, and then measuring post-void residual. This can involve a bladder scan most of the time. What we do a lot of times in the hospital is we have them, before they void, we scan their bladder, see how much is in there. They void, and we count how much that is, and then we scan them after, which is the post-void residual, to see how much is left. So for example, say a patient has 400 mils in their bladder, they urinate 200, and now they have 200 still in their bladder. That's not a true void, which is not, or it goes back to that urinary retention. Sometimes we need to do surgical therapy, which treats the cause of retention, such as enlarged prostates. Sometimes they need stents. There can be a lot of different surgeries to kind of prevent this. Drug therapy for urinary retention. Big one is adrenergic antagonistic blockers. The big one, Flowmax. It reduces urethral sphincter resistance to urinary flow, helps them be able to void. It is used a lot with men with BPH. So you'll want to spend some time in this section of the instrumentation. This is really talking about the management of catheters. You'll see a lot of questions of, you have this patient with this kind of catheter with these kind of symptoms, what's going on? So spend some time in this section. It talks about urethral catheterization, ureteral catheters, suprapubic catheters, nephrostomy tubes, and intermittent catheterization. The big thing that you want to think is sterile technique when accessing different areas. No unnecessary catheterizations. There's none of this, we have to keep changing her diaper every 2 hours, so we need to put a cath in. That is not a thing anymore. We really want to keep catheters out of people. Now, if let's say that same individual is urinating a lot, but has some wounds on her buttocks, then we might need a catheter to prevent from the site from getting infection. Another thing to think about is intermittent catheterization. Some patients self-cath at home. And they come into the hospital and we give them the material and they self-cath. It's making sure that they know how to do it correctly and sterilely. This is just a nice picture of a nephrostomy tube that kind of shows how it looks. One question you might see come across is where to place the bag. You always want to place the bag in a specific location, aka, think gravity. You don't want that bag going back up into the kidneys and causing infections. This is a very high risk of infection, so we want to prevent as much as possible.